Assalamu alaikum wa rahmatullah, dear friends and my fellow orthodontists, that I'm very happy with the grace of Almighty Allah that I have become the first and only platinum Invisalign provider from Jammu and Kashmir and Ladakh. And now this video will be highlighting some of my cases, but this second video I have kept very precise. Only one case will be shown in this, and that case is just ongoing, just present and the mid treatment. So for further videos it will be uploaded how is the progress going on. So coming with the clear aligner system, as we know that Invisalign is from States of America, and they have just an R&D of 30 years in this, with the research more than 30 years, and they have treated more than 2 crore cases till now with the doctors in more than 180 countries. So I am one of their members in Jammu and Kashmir, and this year I completed more than 50 cases of Invisalign, and I will be showing the first case here, as mostly I am taking the cases of kids, because this is the most these are the kids which are being kept like away from the treatment, where we need to intercept as early as possible. Now treating 7 and 8-year-olds with Invisalign First, that is one of the portfolios of Invisalign. Invisalign First involves interceptive orthodontics, which is suitable for children aged 7 to 10 while they have their primary milk teeth. Now, most of the times when the patients are coming and they are having a dialogue that, sir, that our kids are having primary dentition, is it possible to go for the braces? Yes, we can go for the braces. There is no doubt in that. But for a kid, it's a bit cumbersome that with the brackets and wires, we have the system for that. But now we have the advanced system. We have the advanced system from States of America called as Invisalign First for kids, where we need not to have any wires, any brackets, just a simple smart track polymer plastic will do the miracles. Now, this is one of the case which will be presented in 4th or 5th video. Like you can see that this is the pre-treatment and the post-treatment, and just this is the palate when he came to me, and this is just after 3 months. Just in a span of 3 to 4 months, you can check the expansion of his upper arch. So now, why the growth phase is important? Because during the growth phase, muscles and bones can adapt more readily to external forces compared to adults. Because these kids, they are in a growing stage, and their bones and muscles can be adapted to forces. But most of the times, the orthodontist says that we have to wait for the permanent dentition till 12 and 13 years. Until that time, this modulation is gone and we are not able to modulate, and later on the patient either lands up in surgeries, or we have to extract his or her teeth, and then we have what we say in our language, we have not a full scale results or full scale treatment. We say it's a compromised treatment. Now coming on to this case, like this is a case where we have the smiling photograph, and just have a video before I progress.
My name is Davion, and I have excessive overjet and maxillary spacing. My name is Edward, and I have a canine crossbite and edge-to-edge bite.
My name is Roxy, and I have a bilateral class 2 bite with narrow dented arches and maxillary and mandibular crowding.
These kids are cute. They need more care from our side.
It's designed just for me. There's no sticky stuff. I can eat what I want, and it's easy to brush.
I can wrestle.
I don't have to sit in this chair as much. I get new aligners every week. And I can still see my teeth.
And best of all, I get the smile I want.
So these smiles deserve really, we say, a care we should be giving to them. So treating kids of 7 and 8 years by Invisalign First, by interceptive orthodontics, and this is a growing phase as I already discussed with you. So we should be hitting the bullseye and we should be on target. Now coming on to the first case, this is the first case, and you will be surprised to know that the age of this little girl is only 7 years. She is 7 years old and she is having the symptoms of obstructive sleep apnea, where a patient is having, in the night he needs a more amount of oxygen deprivation is there because of the constricted palate and because of the tongue position. Inshallah, I will be uploading a video for the obstructive sleep apnea. That's not the time to discuss here. So this is the case where you can see that the patient is having a small mouth or a microstomia, and because the interpupillary distance is equivalent to the width of the mouth. So a microstomia is one of the signs of OSA, and you can see her smile, less incisal show because of open bite. And profile is convex, associated with retro positioned chin. So these are the extraoral photographs of the patient. And this sweet baby, this sweet girl, and was very much, she was very much willing to get her treatment done. As also you can see that this is called as Turkey gobbler appearance. One of the questions which is being asked to the postgraduate students, if they want to know about this, they can refer to the Epker and Fish, one of the classical books of integrated surgical and orthodontic dentofacial orthopedics regarding this Turkey gobbler appearance. And it is mostly in the class 2 patients and in patients who are having a skeletal open bite, and where we don't have a chin throat angle which is defined. It's like a called as Turkey gobbler appearance. There are many reasons for that, like we have a more amount of submental fat depositions, or a patient who is very fat, or a low-lying tongue position. Now this girl, this child is having a lower 1/3 having a greater dimension than the upper and middle third. Why? Because her mandible is rotated in a clockwise fashion. That's why the lower 1/3 is having a greater dimension. Now these are the intraoral photographs. We have a constricted palate and we have an anterior open bite of 2 to 3 mm. We can also see the occlusal plane, the anterior part of the plane which is up. Same for the palate. It's a severely constricted palate, and this is the left buccal having the occlusal plane. We can see the anterior part is up, and this is a lower occlusal view. And one thing is that this patient didn't allow me to take the photographs, because once she was opening her mouth, because she's a mouth breather, so once I tried to put the mirror in her face, she was grasping for oxygen. She wants oxygen. So I will show you the difference now and after, once the here mid-treatment I will show you. So these are the intraoral photographs which I just discussed with you. Now let's come to an important aid which helps us in diagnosing the cases. That's our lateral cephalogram. Here you can see the position of the hide bone. You can see that there is no chin throat angle, and the yellow circle shows there's a 1-point contact. It means that the posterior maxilla has descended down. And upper and lower airways. This is the McNamara, as we know, the McNamara analysis which we do for upper and lower pharyngeal space. Even though that's not the gold standard, we have to go for the MRI for checking these, but still I checked for this on 2D, and you can see it was coming only 4 to 5 mm and 8 to 9 mm. So severely constricted nasopharynx and oropharynx and laryngopharynx, these airways. As this is a skeletally open bite case, so these patients are having a fish mouth appearance. If you see the OPG, you will see that like a fish opens the mouth, in the same manner we have that appearance. And also they have an antigonial notch, which is a classical sign for a vertically growing patient. Now these are the parameters which we are seeing, SNA, SNB, the gold standard stereo analysis, and it turns out to be A and B of 6 with a skeletally class 2 pattern. And mandibular plane angle of 44 degrees. So almost from 32, 33 to be the normal GOGN to SN, it's coming to be 44. So severely vertically growing patient, high angle case is this. and IMPA of 97, even though a decent IMPA. It means the lower incisors are on the maxillary bone, they are in a perfect or in a normal inclination. Now maxillary and mandibular plane angle is 40 degree, and regarding the FOP, the functional occlusion plane, if we try to draw a functional occlusion plane on the molar and the premolar, we will see that there is clearly from the stomion, the point where the upper lip and lower lip touches, and here we can see that is clearly the plane, the maxillary plane is going in a anti-clockwise fashion, because 40 degrees is a high angle for the mandible and maxillary plane. So I checked for the facial height anteriorly. It was increased because of the rotation of mandible, and also for the posterior facial divergence came to be 40 degree. It means that a short ramus is there, the ramus is short, and the gonian angle has increased, and anticlination of palate is 100 degrees. So these are the typical classical signs of a skeletally open bite case, and here in this we have 100 degree anticlination of palate. It means the palate is going in the anti-clockwise fashion and the mandible is going in the clockwise fashion. Regarding dental and soft tissues, we can see lower incisor to NB is 24 degree, that's okay, with 4 mm anterior posteriorly. Upper incisor is 38 degree. It should have been 24 degree. It's coming out to be 38 degree. It means the upper incisor are severely proclined. And 8 mm, they are away from the NA line. Lower lip comes to be retrusive. And coming on to the width appraisal. See, we can have a doubt that when we try to compare the cranial base with the maxilla and mandible bone, there can be a changes in the cranial base. But width appraisal is also called a gold standard while we'll check the maxilla and mandible relation, because it is a relative comparison of maxilla and mandible. We are not comparing it with the skeletal base, but in that also width appraisal comes out to be 7 mm and skeletally class 2. Oh my god, nasolabial angle is 128 degree and nasal tip is up. It means in future this kid may be going for a rhinoplasty for her nose, because the columella angle is a lot, it's a lot high than the normal it should have been. 128 degree, as we know, the ideally it comes out to be 100 and 110 for the Indian population. So nasal tip is going up and posterior maxillary height is 55. It means if the posterior maxillary height is 55, it means that the maxillary descent from the posterior maxilla, that the maxilla is going down posteriorly. So what is our diagnosis? This is the thing which we need to address. This is the thing which we need to reach out first. Diagnosis comes out to be 8-year-old female, because now she has turned to be 8. Once I started, she was 7.5. Now 8-year-old female with skeletally class 2 jaw on account of retrognathic maxilla and retrognathic mandible with severe vertical growth pattern, angles class 2 malocclusion with severely proclined and forwardly positioned upper incisors, normally positioned lower incisor, and anterior open bite. So what are the problem lists? What are the problem lists that we need to address here? What are our objectives? Number 1, correction of anterior crossbite and posterior crossbite. Posterior crossbite because of constricted palate. Rotation of mandibular plane to normalize the anterior facial height, because the mandibular plane is rotated. We have a convex profile and a retrognathic chin. Correction of palatal plane by rotating it in clockwise direction, because we need to correct it, and we need to increase the incisal show, and correction of nasolabial angle, and correction of mouth breathing and OSA. So the planning will be, we need to expand the palate, we need to extrusion of anterior teeth, intrusion of posterior teeth, height, bone and tongue position correction, mandibular rotations. These are our treatment planning. So this was the clean check for the Invisalign First patient. Here we can see that she was having on like 38 aligners. This is the anteriorly and this is the right buccal, where I have tried to put the anterior lower ridges, power ridge in the anterior region, And the thing is that I cannot distalize the arch because she's a high angle case, because I will be exaggerating her open bite. So I planned for the intrusion of the maxillary and the mandibular molars simultaneously, and expansion of the maxillary arch, so the palatal plane can be rotated in the clockwise direction, and the mandible plane, as it is the dependent arch, it got expanded. These are the eruption compensation because the first premolar has not erupted. These are the milk tooth on the right and left side. This is the milk teeth on here on this aspect also. So just after this, the mid treatment, after 5 to 6 months, you can appreciate that now we are getting from a zero overbite or zero overbite to a positive overbite. We have decreased the overjet. We have expanded the palate. We have expanded the palate here. Along with this is, you can check the occlusal plane. Now it is the functional occlusal plane is coming to the upper anteriors. And here we have the plane, superbly done in 4 or 5 months, thanks to the technology from Invisalign from States of America. Now it is available here in Kashmir also. You can treat your kids from this technology, and you can see the mid-treatment just after 5 months. The treatment is going on now because now we have gone for another refinement scan. These are the pre-photographs. These are the post photographs. So what I want to emphasize is that these kids deserve treatment, and they can be treated at an earlier age by interceptive orthodontics. No wires, no brackets, just a simple smart track plastic. Because if we are not treating this kid and we are deferring her treatment for 12 or 13 years, this is a clear-cut case of an orthodontic surgery. Likewise, there are so many kids roaming here from one clinic to another. They need treatment, but as a responsible doctor, we should try to address these kids and we should treat them at an earlier, because the changes which we will be bringing now, it will last for a longer time rather than going for the compromise. So for the final results of the patient, for the final smile, stay tuned with Dr. Junaid.